Our next speaker is Eye Health in Australia by Professor James Elder from Australia. So, yes, Professor Elder, please.
Thank you, Jason. Thank you for inviting me to present on this. First, a few words about Australia. It's a small country compared with where we are now. A population of 27 million, that's not even the population of the city we're in at the moment. We are have a relatively reasonable birth rate, but less than a quarter of our population is under 15. That's 5-year age groups between 0 and 20, sorry. Australia is a wealthy country, and that obviously makes a difference on the provision of any health service. And typical with lots of countries, the wealth is not evenly distributed. 10% of the population have 46% of the wealth, and the lower 60% of the population have 17% of the wealth. As you can see from this chart, Australia ranks fairly highly in countries around the world with net worth, so a wealthy country. In keeping with that, life expectancy is good. We have diseases of chronic health, and people live for a long time, so a lot of cancers, mental health problems are common in Australia overall. Getting to children, where are they? Well, they're distributed around all the different states of Australia. Just to give you an idea, there's a graph at the bottom of 1,000 kilometres. When I flew here from Melbourne, it was 3 hours and 55 minutes before I went over the coastline. So nearly a third of my flight here was over Australia. The other 2/3 was getting the rest of the way to India. So just under 5 million children under 15. And this looks like they're scattered evenly around the country, more in the east perhaps. But if you look at this population spread, 70% of the population are in the dark blue areas in cities. So in many respects, we're like Singapore. We all live in the towns. And less than 1% live in the vast majority of Australia. That has correlations with disadvantage. So in terms of access to services and things in Central Australia, where only 1% of the population is, it's very hard to access services, though half of our Indigenous population live in that area. They live in areas where it's difficult to access services, so that's perhaps right. English is spoken widely, though nearly a quarter of our population, because we have a lot of recent immigrants, speak languages other than English at home regularly, but only 2 or 3% classified from census data as having poor proficiency in English. What is eye health? Well, it's how well you see, vision, whether you've got healthy eyes and eye diseases, and how well you function with the vision you've got. And this Lancet Global Health Commission eye health cartoon is very helpful because that gives you an idea of how that translates into well-being and inclusion and quality of life. So what data do we have and where does it come from? So some's from government data, some from research studies and reports and registers. So there was a government report published nearly 20 years ago that suggested that there were nearly 500,000 Australian children who had some eye health problems, but this was mainly refractive error, and it was perhaps criticised for its methodology, though the number of children that have hospitalisations with eye disorders is probably much more accurate, and that's comparatively a much smaller number. Preschool screening, it's universal in the country, but the methodology is variable. The best documented and studied system is what's called the statewide eyesight preschool screening in New South Wales. It's offered to all 4.5-year-old children, and it's a linear visual acuity. A publication, again, it's 10 years old now, outlines the strategy. So 6/9 or better, you're a pass. That's 80% of children of this age. Miss a couple of letters, you're borderline. They recommend retesting in a year. Not really get 6/9, routine follow-up, that's 6% of the population. 6/18 or less, 2% of the population. And less than 1% were unable to be tested. I put this thing here as sort of a false positive. So of these children that were referred for routine things, how many of them really didn't have an eye disease? It's 10% for the ones that are modest visual loss. For the ones with higher visual loss, the testing is much more accurate, as only 2% were actually subsequently found not to have a problem. And so this is quite effective and useful, and we're trying to adopt this nationally. There were some studies done in Sydney a while ago looking at visual impairment. Though unfortunately they described it as less than 612 across an urban population in Sydney. Very few of these were serious visual impairment. Most of the, well, as in ones that weren't potentially treatable, like refractive error and strabismus. Visual impairment due to serious oculopathology in preschool-aged children in Victoria, in New South Wales is low, does have an association with low birth weight. The Sydney myopia study has looked at use of glasses. Again, this data is fairly old. What I think the most important thing is the bottom line is that there's very few children who need glasses who don't get them. So an affluent country, you can get glasses if you need them. There is a register of visual impairment, children who have vision less than 6/18. It's voluntary and not that many people are enrolled in it. In keeping with other developed countries, abnormalities in the visual pathway, retina and optic nerve are high up in the lists of causes of less than 6/18 vision in the Australian population. But this is a relatively small number. I mean, there's many more than 800 children with visual impairment, and this was 10 years data for this registry. And that just gives you some idea of the level of vision seen in those children. There's another recently published study that looked at the eye problems in 3-year-olds presenting to a tertiary hospital, and this gives you some idea. And again, it was data collected over, I think, 5 or 6 years of 3,000 children, and these were the causes. Strabismus is in the other category because the WHO classification of vision impairment doesn't have a nice classification for strabismus. You can see that the highlighted areas there are the ones that relate to the register. I'll just bring it up to this side to compare it. So in young children, visual pathway reasons for visual impairment are similar to what's seen in the register, and that probably makes sense because of their congenital abnormalities either in the brain or the optic nerve, like optic nerve hyperplasia. The rate of retinal impairment in under 3-year-olds is lower, and that's because in older children you'd have retinal dystrophies that take time to be manifest. And interestingly, in that group, amblyopia was much more common, and that makes sense. That's when you're detecting amblyopia. Myopia in Australia, is it the Asian tsunami, or is it calm in Australia? You know, what's happening with that? Bit difficult to get good data, but the Sydney myopia study has a couple of publications in which they followed people up after a 5 or 6 year period, and that shows that the rates are increasing, but the rates are much lower than obviously was reported in the previous talk. So it's less of a problem. It's probably related partly to sunshine, partly to ethnicity. I think in large measure related to sunlight. The workforce in Australia, there's 1,000 ophthalmologists, but not many paediatric ophthalmologists. In the public hospital system where the training occurs is effectively 16 full-time. I mean, to give you some idea, I only work 1 day a week 2 days a week in the public system, so I'm 0.4. But across the whole nation, there's relatively few. In private practice, probably more. There are many more optometrists, and we have a good supply of orthoptists because there are 2 university schools of orthoptics in Australia. Paediatric eye care, this is not paediatric ophthalmologist, is dotted where the population is. New Zealand sneaks into this one. This is where ophthalmologists are, so very few in Central Australia and other places where there's less people. And there is cause for concern in Australia about an impending shortage of paediatric ophthalmologists. For a variety of reasons, similar to other parts of the world, it's difficult to recruit people in ophthalmology training into paediatric ophthalmology, but we're working on it. So the conclusions I have is that a wealthy nation, we have good resources, so most people who need healthcare can access it, though there can be geographic difficulties and workforce supply problems in more remote areas. There seems to be in children a relatively low rate of avoidable vision impairment, as you'd anticipate. The challenges relate principally to geography and distribution of the workforce and ensuring that we have an adequate supply of paediatric ophthalmologists going forward. Thank you very much.
Yes, any questions from the floor, please?
Yeah, it's a very nice presentation. Just want to also that map. There is a geographical map regarding the I think rural red color, yellow. Can you go to that map again?
Can we have the talk back up to have the maps?
So
Can
by
I
that
load
time,
the talk again, please? So was it the population or the socio-economic standard? Because both of them were coloured red.
population, I think.
Yeah, I'm not sure whether they can get it up. Anyway, I
Okay,
ask you.
by that time, yeah. So whatever the data you presented regarding the school screening, I think.
Yes,
School level screening,
so
that
the
is-
school screening in New South Wales, the thing that they have there that's very well developed is they have what they call local government regional health areas. And the way it's funded, the preschool screening does happen in the remote areas. And in fact, they showed that the uptake in some of the more remote areas was higher than some of the urban centres. And so I didn't have time to present all the data about that particular screening protocol, but the uptake for preschool screening is quite good. Children tend to be in towns and cities, and so if you can visit, even though it's a small town, if you can send someone there, you get most of them. And so they still only screen about 75% of the population that's eligible, so 25% of children don't get screened for a variety of reasons. That was in that publication from 2014. They actually are getting that up. I think they're closer to 80% now on more recent unpublished data. But they specifically have funding to go to the rural areas for that.
Interesting. And second thing was regarding the diseases identified for the visual impairment, that is based on the worst eye only.
Yes, that's binocular visual. So that visual impairment register, it's binocular visual acuity less than 618 or field less than 20 degrees, or they have any child with cerebral visual impairment, because often those children, you can't either document the field or the visual acuity, and so the inclusion criteria for that registrar was best corrected binocular acuity of less than 618 or less, which is consistent with the WHO definition of vision impairment. And that was the problem with the other Sydney study. They, for some reason, chose 612. I suspect probably it was so they could look at uncorrected refractive error and things like that, which is what they demonstrated in that study. Yeah.
Thank you.
Hello, Dr. James. Good afternoon. Yeah. We all know that the climate can have really bad impact on the eyes of the children, especially when it comes to allergies and all. I would like to know in Australia what is the pattern of allergies and how significant are they?
Yeah, so allergic eye disease is quite common in the city that I work in, Melbourne, because we're surrounded by an enormous grasslands and farming, and so there's a very high pollen load. So allergic eye disease of all sorts occurs relatively frequently. Sight-threatening allergic eye disease is fortunately relatively uncommon, and again, most of those children, because of their symptomatology, access care and get treatment. But allergic eye disease is not uncommon. And then it was, I didn't talk about it specifically, but in that study of under 3-year-olds at the tertiary hospital in Sydney, I think it was 10 or 15% of their patient group had ocular surface disease. Now, some of that would have been infective, but some of it was allergic even in 3-year-olds. Yeah.
Do you take interest in screening for other allergy of the body issues like asthma or any other things also?
Yes, and so in keeping with that, atopy is often a body-wide problem. We've had problems with what's called thunderstorm asthma in Melbourne, where you have these weather events during the pollen season in which a huge amount of pollen is stirred up and basically dumped in the city, and so we've had issues with lots of people having acute asthma episodes with that. Asthma as a disease in Australia is much better controlled than it used to be, and that's again because of a well-funded health system. People can access appropriate suppression therapy for their asthma, and so severe life-threatening asthma has become less common.
Thank you for that.
Thank you, James. Can I ask a question? Wonderful talk. Thank you very much. In Australia, such a big area country with relatively less population, very scattered, are there any role for the digital medicine AI in terms of improving the healthcare access or advancement?
So there is some in terms of digital healthcare. I'm not so much aware of whether AI has been employed here, but certainly during COVID we used telehealth. We published an article about parental satisfaction about that, and people were very happy with it. I have colleagues in Western Australia who do quite remote care in the northern and inland parts of Western Australia, and they use telehealth there, though it's often in the method of supporting. So there's someone who does, say, retinal photography for diabetic retinopathy or anterior segment photography for cataracts, and then it's interpreted elsewhere. It's not a truly consultative process, but that's a problem that bedevils all telehealth as to how much consultation you can do and how much you can have data for expert interpretation elsewhere.
Thank you. Thank you. Yes.
Yeah, that was a wonderful talk on the eye health, child eye health in Australia. I had this question. So you mentioned in one of your slides about the different ocular diseases of children who presented to a pediatric eye care center. And I think close to 50% of them were normal, and they had come for screening purposes.
So one of the largest diagnostic groups there was, because it's a tertiary hospital, is internal referrals. So neurology sending a patient, do they have headache? Rheumatology sending a patient with JIA, do they have uveitis? And things like that. And in an under 3 population, so that was a large part of the workload for under 3. I'm sorry I don't have better data for sort of the whole range of children in terms of looking at the literature.
Okay. No, I just wanted to check if that would include the uncorrected refractive errors as well. Were they identified?
Include?
Uncorrected refractive errors?
No, there wasn't much uncorrected refractive error there. There was a section on, I thought there was a section on amblyopia, and also in that other section, that's where the infantile esotropia was and things like that. The classification is a little clumsy because it uses WHO visual impairment or sites of disease, and strabismus is classified as other in that, as I understand it.
Thank you.
Hi, Dr. Elder. I'm here.
Yep.
Here, I'm speaking.
Oh, sorry.
Yeah, that was a wonderful talk. It just gave us a bird's eye view of children eye care in Australia. I just had a question on the workforce that you mentioned about. It seemed like the urban areas have a concentration of eye care teams located. And I was curious to know what percentage of population, basically the childhood population, lives in the rural parts.
Yeah.
Are there any?
Yes, so that again was on that graphic of the map. 80% of the population lives within a couple of hours' drive of a major capital city. 20% is a bit further. Sorry, no, take back. 90% lives within a couple of hours' drive of a major capital city, and 10% are more remote. We have a number of initiatives to try and move the workforce more rurally. In our training program, we have rurally targeted trainees who do the majority of their training in a larger rural area, and they hopefully will practice in more remote areas. Most of them are as general ophthalmologists. We only have a handful of paediatric ophthalmologists who practice outside major centres. We have a few, but not many. That's a difficulty. So it means that children who are remote, I mean, in my clinic, I would have children that have travelled 6 or 7 or 8 hours to see me because there isn't an appropriate
Do you have any information on the availability of care or the need, the difference between the needs among the urban children versus the rural population?
The needs are probably similar because it's a fairly uniform. I mean, we probably see more myopia in the urban population, just as you'd expect from all of the other studies. So my refractive error is probably more common in the urban population. Other than that, I don't think there's a lot of big geographic difference, except perhaps with the remote indigenous population, because trachoma is still exists in Australia despite many efforts to eradicate it, and so there would be a small number of children in very remote Australia who still have trachoma or at risk of it.
Okay, thank you. Yeah.